Good afternoon to uh, fellow colleagues at the 54th Annual Conference of the Indian Association of the Physical Medicine Rehabilitation Specialty in Kochi, India. I'm going to be talking on my research journey with therapeutic dextrose injection, and this version is actually likely to be a little bit more than an hour, since my usual talk here was 20 minutes, and it will be able to fill in some details, especially with research applications. And I'm going to try to be speaking at a level that's uh, easily understandable for both colleagues from India who are so intelligent, but this may be a second language, and also for patients that may be interested. So going on, therapeutic dextrose injection is the injection of dextrose to reduce pain or improve function by targeting one of several things. If the injections are into soft tissue like ligaments and tendons or into joints, the term for dextrose injection would be dextrose prolotherapy. And the intention there is to, if necessary, improve the status of the joint or soft tissue by creating new growth. What we're primarily interested in is pain and function, but if necessary, the tissue will grow. Now, the next approach of therapeutic dextrose injection is of nerves primarily under the skin. This is termed perineural injection treatment, or PIT, and was introduced by Dr. John Liftoff from New Zealand, beginning in approximately 2005. And there is no proliferation here. This is specific to reduce pain and improve function. And the third area of therapeutic dextrose injection is becoming rapidly more popular is the treatment of deeper nerves with ultrasound guidance, because deeper nerves will often become entrapped. And you can stretch these nerves free with ultrasound guided hydrodissection. So those are the three types of therapeutic dextrose injection. I'm going to present the first part of this talk by true and false statements. True and false, dextrose is researched the way it is performed. This is false. Dextrose prolotherapy is performed regionally most effectively, it appears, but is studied focally. And let me explain. I completed my physical medicine rehabilitation residency in 1983. I began learning about dextrose prolotherapy in 1990, and I found it more helpful when I treated patients regionally, trying to address all pain contributors. I got this idea because training in prolotherapy often occurs in something called service projects or missions type experiences. These have been offered for 45 years or more in areas such as, most commonly, Honduras. And the thing that struck me about those service projects when I asked about them was that patients come only yearly. And I was told that when they come back the next year, they often want something else treated because they still are sustaining improvement. That's what caught my attention, because I was used to pain treatments that did not have much lasting benefit. Um, However, you can't really afford to do studies that are complicated, especially for dextrose, which has no money for research or very little. And so from a pragmatic standpoint, pragmatism and lack of funding, I concentrated on maximally focal treatment designs. In 1993, I decided this must be studied, um, and I began two intra-articular injection only. In other words, only into the joints in 1995. And this had to do with knee arthritis and finger arthritis. I did this despite expecting only partial benefit compared to regional treatment, but it was the only practical thing to do. I expected enough improvement to show it was still effective. True or false? There are four areas of level B evidence for dextrose prolotherapy efficacy. This is also false. As of a few days ago or early February, there are now 9 areas with level B randomized controlled trials. And this is a high quality randomized trial, which has several things in common. Um, in general, these studies have in common an injection control, multiple treatment sessions, which is important, especially with focal treatment. Several sessions are often needed, and 6 to 12 months of follow-up. You can see here temporomandibular dysfunction has 3 randomized trials that are strongly designed, and there's many other studies as well. This is probably, along with knee arthritis, the most studied condition for proliferative injection and particularly dextrose prolotherapy. Shoulder pain has 1 randomized trial, as does wrist pain. A hand osteoarthritis has 2 randomized controlled trials that were well conceived and carried out. Low back pain, the one that was in 2010, involved patients whose pain was from the sacroiliac. And this was determined in part by injecting the sacroiliac with anesthetic before enrolling the patients in terms of the formal ongoing clinical trial. And those that had 50% or more improvement in their pain were considered to have a sacroiliac source and were enrolled. So they were either given an injection of dextrose or triamcinolone, and there were 1 to 3 sessions. Now, triamcinolone is a steroid, so they were comparing dextrose to a steroid. The next study was on low back and leg pain, and this is the one that was just recently accepted by the journal PM&R. And this was compared epidural steroid injection, which is still very commonly done, to a limited treatment set of dextrose prolotherapy. Knee arthritis has a number of clinical trials, has been stated, both of intra-articular only and a limited treatment set. There's no treatments for the conditions above that include both dextrose prolotherapy and other forms of therapeutic dextrose injection. So keep that in mind. Osgood-Schlatter disease has 2 clinical trials, both of them quite favorable. This is a condition which some people minimize, saying, well, you'll grow out of it. But these athletes can suffer for quite a long time. It can knock them out of their favorite sports. Imagine a Michael Jordan who had Osgood-Schlatter disease and never was able to continue basketball. Ankle instability is another study that was recently published in 2025 by Dr. Sit in Hong Kong. Now, the number of clinical trials are growing, and as an example of the increased interest, I'm receiving 1 citation or more daily on average. But the variation in research outcomes is going to continue to be too high for the evidence to be related as level 1 or level A, because a meta-analysis is what determines the overall quality of evidence. And to do that, they collect all the trials and see how closely they agree. Unfortunately, because dextrose is easy to study, many people do research and are not prepared. They will do things like use inadequate treatment intervals, not allowing time for repair of tissue. They may see a patient, treat them every week, and that is a weak way to study this. Also, they may not understand that, especially for focal treatments, you need to have typically more than 1 session. So they'll do inadequate treatment sessions, or because they've not been performing dextrose prolotherapy a long time, they may miss the primary nociceptive, which means the primary pain source in their treatment. And there's also confusion of terms. For instance, perineural injection treatment is not prolotherapy. And some people will consider it prolotherapy and publish a study calling it that. Now, these type of problems we're more than glad to help with, so that all the hard work of research designs does not result in a less favorable outcome. Feel free to contact, but that's an important point. Now, another point about this is that when I began research, there was not any high quality research that had been done, and the practitioners of dextrose prolotherapy were being attacked by folks that were doing surgery or had other vested interests in suppressing non-surgical methods. So these studies were initiated in large part to protect um, physicians that want to do this low-cost treatment and keep them protected from medical boards and other sources that may not know the literature very well by making sure the literature is there. So here's the next true and false statement. Dextrose prolotherapy proliferates weak, soft tissue. This is false as well. Dextrose prolotherapy proliferates histologically normal, so that means under a microscope, and apparently stronger and thicker soft tissue of various types. In this slide, you'll see mention of muscle cell regeneration, um, a study on wrist flexor tendon tissue, a study on Achilles tendon healing, a study on fibrous membrane healing. That's something, a term is dura mater, which is close to the brain, and partial cartilage repair. So those are the types of studies, and there's a few interesting portions of the slide I'll draw your attention to. One of them is the load to rupture in millinewtons. This was where um, the orthopedic research laboratory at Mayo Clinic was doing a study to make carpal tunnel happen. And they were doing it by injecting around the flexor tendons of the wrist to make them grow thicker and press on the carpal tunnel. Note that dextrose injection is being used to treat and reverse carpal tunnel, but this is a different application. This is not injecting to free up the nerve. This is injected to make the tendons in rats, the sheath, fiber sheath to grow thicker. So here's an example. They actually were able to take out the tissue after treatment, and they noted the load to rupture was more. It took more load to rupture this tissue. Also, the total energy to rupture in joules was increased substantially. And most easy to see on this slide is the increased thickness. So here's a normal saline, which was the control side, and here is the side that was treated with dextrose. And you can clearly see the increased thickness, and this approximated double. And this was with 1 to 4 treatments. Even one treatment did create repair. At the bottom of the slide is information from pre and post treatment arthroscopy in knees that were grade 4. This was done in Argentina. And it was done on grade 4 knees because these are knees that are denuded of cartilage. In other words, bone on bone in large areas. And the white you see on these slides is areas of no cartilage. This was chosen, this severity, because you can see new cartilage grow by using a methylene blue stain. Before and after treatment, you can see that the stain is taken up by a larger area post-treatment than pre-treatment. So there's an actual hole that's been filled in that second photo here. And we took biopsy from sites of growth, and then we showed the actual picture of where the biopsies were taken. And these areas showed growth in approximately half of the sites. The knee was broken up into sections in a standard way to at least to systematically run through these arthroscopies, which were read in a blinded fashion. Now, all the citations here are go to the particular studies in question. True or false? Dextrose prolotherapy works by causing inflammation to start repair. This is very commonly stated in current studies that Dextrose prolotherapy creates irritation or inflammation, starts an inflammatory cascade to begin repair. We're going to begin dealing with that, true or false, right now. Dextrose prolotherapy actually causes minimal to no inflammation in vivo. So this is a study on real living animals or people. One interesting study was done at the University of Wisconsin, where they found that when you injected in an animal, this is medial collateral ligament, a knee ligament, they injected with dextrose, they injected with saline, and they injected without any injection, but just simply by placing the needle in the same locations. What they found is there was a minimal or small inflammatory response by the needling, and it was no different if dextrose was included or saline was included, suggesting needling has some inflammation associated, but it's not much. Next, in the study I mentioned before, showing tissue growth, growth of normal tissue that's thicker and stronger, also found was if they made a small incision at the wrist level and inserted the needle through that incision without needle trauma right into the area around the tendons, there was no white cells, there were no white blood cells seen at any point in time. So they took biopsies at several points, and without white blood cells, you cannot say there's inflammation. So these are two useful studies. So the next true and false is dextrose prolotherapy works through a hyperosmolar stress effect. This also appears to be untrue. Dextrose prolotherapy appears to cause osmolarity for only minutes. Now, for those that are not familiar with osmolarity, just note it relates to the concentration of things in solution. And if the osmolarity is too high or too low, it can stress the cell. Now, there's a diagram on the right here. Now, what this represents is the dextrose concentration over time. This is actually a human knee. Specifically, it's my knees. I was getting tired of this dogma. And so my knee, I injected my own knee with 30 milliliters of dextrose 12.5%. I use that much, which is a whole ounce, because I don't have much effusion of any in my knee, but I wanted to be sure that dextrose started out concentrated so that we could see the curve. For those of you that use 25% dextrose, you'll notice that most people have enough synovial fluid, they're going to dilute that 25% very quickly in the synovial fluid. So this actually would represent a large amount of dextrose load put in a human knee. Now, a human knee was chosen because it seems to be a closed system. And one would think if dextrose was going to hang around for quite a while, it would do so in a human knee. But indeed, what happened is you see the curve here, the dextrose level dropped very fast in a S-curve pattern or exponential pattern. The point at which the osmolarity is likely not high anymore is about 7 minutes. Now there were 3 trials of knee injection, 2 on the right, 1 on the left, and they all showed very similar curve patterns. So what does this mean? This means that part of the reason there's a misunderstanding of what prolotherapy does and why some people still say it's inflammatory is because the way it's researched in vitro, which means in a test tube primarily, is that they would expose cells of various types to 24 hours of dextrose at high concentrations. And what happens to all cells in humans and in animals too is that they die. And when cells die, they release their cell contents and their cell membranes break down. And those lipids or fats are inflammatory in nature. So this is why the in vitro research using those methods came to the conclusion dextrose was inflammatory, but that was grossly inaccurate. And we are recommending that if in vitro studies are done in the future, they be done with very brief exposure to dextrose and then have the cells washed to remove that excess dextrose, or that they use only small concentrations of dextrose, um, such as up to 0.5%. True or false? Dextrose prolotherapy has powerful non-energetic anabolic roles in diverse cells. Okay, now let's break this down. Anabolic does mean growth encouraging instead of breakdown. It has to do with building up. Non-energetic means that this is not related to the fact dextrose is a sugar, but that it has some unique qualities. We don't know how it works. Much more research needs to be done, but there are some non-energetic roles that have recently been found. Let's mention several studies. First, dextrose acts as a direct signaling molecule, modulating transcription factors that control differentiation. So and then dextrose non-energetically activates anabolic processes. So again, the references there are for you to review. True or false? Dextrose prolotherapy is important for single joint laxity treatment. This actually is true, but what's important is that you could do several different proliferative methods for single joint or focal conditions. But if you have patients with multiple joints that are loose, like in Ehlers-Danlos, or like in athletes that have had joints come out of place slightly on several occasions, or even with conditions such as you see here, cervical instability. That's actually pretty common where patients will feel like their head is too heavy for their neck. In cervical instability, for example, you treat multiple areas. You'll treat the facet um, ligaments or joints, capsules, and you'll often inject the interspinous or supraspinous ligament. Now, a word of caution here, you need ultrasound and you need a shorter needle and experience. So mentoring is very important in general across the spectrum of therapeutic dextrose injection. So it's a simple treatment, but certain applications require a particular expertise. Sternoclavicular joint, very common. Glenohumeral, this is a lot of why people get rotator cuff tears. Their ball of the shoulder is not held in the socket, and that ball will drift up when they reach their arm up because it's not kept in the socket quite well, and it'll bang around the rotator cuff tendons or the biceps tendon. So that is addressed by injecting the rotator cuff area or the bicep, but also by tightening the shoulder. Elbow laxity, wrist is particularly common. Costotransverse means the joints between the ribs and the backbone. And these are patients who have been manipulated very frequently, or I should say are getting manipulated frequently. We don't know that manipulation causes laxity per se, so that's not what I'm saying. I'm just saying that if you have someone who's getting a lot of ribs going out of place, you can really help the practitioner and your patient by injecting those rib attachments. But again, here's an application for ultrasound because it's best to go in that joint and treat the ligaments around the joint to stabilize it. Spondylolisthesis, some of you may or may not be aware of, but that's where there's some bone missing and the bones called the vertebral bodies can slip forward on each other, compressing nerves or the residual spinal cord at that level. So it's the ligaments that are being hanged on that's the issue here, and you can inject those ligaments to strengthen them and decrease symptoms. Post-fusion is a very big deal because patients that have had surgery and have had fusion of the bones will have no more motion there, but they'll have more compensatory motion above and below. So we commonly treat post-fusion to limit the progression to surgery. There will be no studies on this, I don't expect, unless an awful lot of research funds are available, because it would be a very expensive study to do. Sacroiliac laxity is something treated very commonly. And symphysis pubis is something to think about for laxity because especially women after childbirth will have that pubic symphysis spread and they'll actually feel motion up in front where that pubis is. Knee laxity is common, ankle laxity is common, and ankle laxity should be mentioned because when you have sprained your ankle, I think many of you understand that a fracture is sometimes better than a ligament sprain because the ligament doesn't necessarily heal as well as bone. And so if that ligament has not healed, the sensation in the joint is not going to work as well because the little nerve, the special nerve cells that are in that ligament are not going to function correctly. So anyhow, dextrose prolotherapy is particularly important for multi-joint laxity because it is so low cost and able to be done in many locations at the same time. A special note here, for patients with Ehlers-Danlos, you have usually in most conditions, except probably the general laxity, you have a tendency not to heal tissue correctly. And you most likely need a little stronger proliferant even than dextrose. And that can be one of several types. I use a low-dose phenol, but once more, I must caution the practitioner. Phenol should not be used except by an experienced practitioner, and again, probably after mentoring. Should be used with caution because it is strong and must be diluted to a precise level, typically 1.3% for use. True or false? Perineural injection treatment, or PIT, eliminates pain from subcutaneous nerves in 5 seconds. Now, before going on, I will tell you up front, this is true, and it is a consistent finding, and this is what allowed Dr. Liftoff in New Zealand to map out the patterns of these nerves that are under the skin. This is really important for therapists who preceded us in understanding the importance of the subcutaneous nerves, and this is where stretching therapy for nerves that therapists commonly do came about because these nerves are important, and they do tend to get compressed just as they come out of the muscle and through the skin, and they can be sensitized along their entire course. But here's what I want to convey here. Although it reliably eliminates nerve pain in 5 seconds, there's only one randomized trial with perineural injection treatment as a solo treatment so far, and that had a flawed method. Not because it was not an excellent researcher, but because the method was immature at the time, and the sources for Achilles tendon dysfunction and pain, called tendinosis, were not completely treated. And it was compared with a known useful treatment. It was compared with eccentric lengthening exercises. It did approximately as well as eccentric lengthening exercises, but still it was not a powerful study in terms of outcome because of those reasons. Much more can be done with perineural injection treatment, but thus far the research here is lagging. I'm going to mention a couple things. For example, treatment of the ventral rami. So there's two nerves that come from the spinal cord, two primary nerve distributions. One is the dorsal, which is in the back, like the dorsal fin of a fish, and the other is the ventral rami, which come around to the front. Those nerves, again, have to go through muscle, and they can be trapped in those areas. And abdominal cutaneous nerve entrapment syndrome, or ACNES, can be treated with prolotherapy. Can be treated with perineural injection treatment. And the next thing is even more important. Very commonly seen is bad cramping pain at the time of the period. So period-related cramping pain appears empirically to respond very nicely to perineural injection treatment with dextrose. Also, options for use of this in research could be comparing dextrose with other injectase types like anesthetic or steroid. For example, Drs. Jacob and Sankaran compared anesthetic with or without dextrose for myofascial trigger treatment. This was not in randomized patients, but was a large size study, And patients um, receiving the dextrose did much, much better. And notably, the groups were similar in nature. True or false? For ultrasound-guided hydrodissection, D5W is the most effective injectate. So this is, again, the third type of therapeutic dextrose injection. Well, for ultrasound-guided hydrodissection, D5W or dextrose 5% of water is likely the most cost-effective injectate and may outperform most injectates because commonly those injectants are um, steroid. Actually, that's the most common. And D5W has outperformed saline for stretching of the median nerve in an area of entrapment. And of course, that is the carpal tunnel syndrome you've heard about. So dextrose outperformed saline in one study and triamcinolone, which is a steroid, in two other randomized trials for release of the median nerve. Now, what this suggests is that dextrose has a separate therapeutic benefit beyond that of simple nerve release. And if those of you that are familiar with electrical testing, nerve conduction studies, and electromyography, it is notable that there is a reduction in there's an improvement in nerve performance. For those of you that do ultrasound, you'll notice a reduction in the edema of a nerve. When these nerves become affected or inflamed, they will actually increase in size, and the little parts of them called fascicles will be bigger. And what happens is those fascicles decrease in size, and then the size of the nerve decreases. True or false, ultrasound-guided hydrodissection with D5W will reverse neuropathy. Pretty dramatic statement, and of course, we have no clear idea about this because ultrasound-guided hydrodissection with D5W in primary neuropathy has no strong research designs yet. Again, it will likely be fairly expensive to study, and it's going to take some time to get those set up. But for reversing double crush effects on vulnerable nerves, and let's back up a second. Nerves that have been treated with chemotherapy, nerves in diabetics, nerves from any number of insults are vulnerable. In other words, as they go down the leg or the arm, there are several places they can be trapped. Those are areas where the nerve can be double crushed. In other words, affected adversely on top of their damage that's already present. And what we're finding empirically now, again, that means non-study, but just by clear observation, it's outstanding to be able to reverse the symptoms of neuropathy by treating those areas of compression, which can be multiple as the nerve goes down the leg or arm. And the other thing that's really important is that with ultrasound-guided hydrodissection, you can release nerves from areas of fascial compression without creating scar formation, unlike surgery. Now, fascial compression is the little layers that surround these nerves, and it can be like cellophane, but of course far more sophisticated. And my purpose here is not to minimize the effects of carpal tunnel surgery, which is a very successful surgery, but it doesn't need to be done in everyone. And sometimes after failure of carpal tunnel syndrome, surgery, we'll see patients for treatment. True or false? D5W decreases damaging nerve inflammation. Now, you know, we said that the basic science of how dextrose works, we don't know a lot about. But our knowledge is growing, and it does appear that dextrose reduces nerve inflammation. And here are two controlled in vitro study results. What they did is they exposed nerve cells, and these were pretty hardy cells. These were stem type cells, and they were exposed to something that is harmful to nerves and common, unfortunately, in the body. It affects a number of people. Tumor necrosis factor alpha. And what happened is when they exposed the nerve cells to this, it shut off their metabolism, made them inactive, and essentially a pre-death or apoptotic state. And then they took these cells and exposed them to various concentrations of dextrose. But you'll notice that, like we talked about earlier, these researchers kept their dextrose concentrations relatively low. And yet, if you look at this, they tested them up to 25 millimoles. That's what that little m, big M means. And that's equivalent of 0.5% in culture. And what they observed is that the metabolism of these nerve cells turned back on. Their survival was preserved, and inflammatory cytokines were reduced, the levels, such as interleukin 6, interleukin 1. Also, cyclooxygenase 2 levels went down, and reactive oxygen species levels reduced. Now, I'm going to talk about two new discoveries about this not so simple dextrose. But before I do that, I think we need to pause for a little humility check here. There is far too much complexity present, even in this one small area of dextrose and all of its interactions, to expect anything other than an incredible designer to have brought about and sustained this multi-layered, interactive, living masterpiece. For example, there are so many ways in which death-causing cytokines can be present with a mutation and kill any so-called organism that's trying to turn from one species to another. So what I'm saying is, I don't find evidence basis for between species evolution, or what's called macroevolution. Yes, within a species, we have flexibility, but not across species. I find the evidence basis is for design. And I'm personally very grateful for the properties of this seemingly simple 6-carbon atom monosaccharide. Now, the following slides show how much we have yet to learn and what fun it will be, especially for low cost and potentially widely impactful treatment options. So here's the first one. An unexpected observation about D5W and PTSD. In August of 2017, I saw a patient that had neck pain and head pain that was very stubborn. Now, it turned out that she had severe PTSD and had flared a year ago because of an event and had not been out of her house without her husband for a year and hid when people came by the house and hid until they left. And she was hitting her head against the wall because her emotional pain was so severe, she was creating physical pain. So naturally, she was a little hard to treat. But in any case, I did not know that at the time. And I injected her for neck pain by using dextrose 5% of water. This was what was called a cervical plexus hydrodissection, because the nerves that supply the skin over the neck and up into portions of the head come out underneath the muscle. So at the top of this slide, you'll see a brownish area, which is the sternocleidomastoid muscle, and the needle is over to the right. Now, you can do this by going through the muscle or under the muscle. And before, you might express concern about the fact that these structures over here include the vertebral artery and the jugular vein. Now, there's no concern here because, first of all, you see where you are. Second, this is D5W, remember. So there is no risk of intra-articular injection with a tiny needle, except you can get some bruising. But you know where you are. That's not been a problem, and there's no anesthetic. And we'll describe further why that's important. But within 1 minute, the patient said, my anxiety is gone. Then she told me her situation. I gave her 3 treatments at a 2-week interval. You don't need to have 1 to 2 months like you do for prolotherapy with nerves that can respond at a shorter time interval. But that was accompanied treatment by a marked reduction in PTSD symptoms, such as she was able now to use the compensatory methods that she had learned for treating her PTSD, and now they worked. She could get out of her house, she could answer her door, and she stopped beating her head against a wall. How could this work? D5W has an analgesic effect on pain, which is which we showed by several studies injecting in the epidural space at the caudal level. Now, this is in the lowest part of the spine. There's a natural opening at sacral level 4, which is called the caudal space. And um, Dr. Smigel in Hawaii did a study with a vertical approach where a tiny needle was placed, typically no more than an inch long, in that area, and dextrose 5% was injected compared to normal saline. And within minutes, the pain was much better on the side given D5W. And these were in patients with back and leg pain. She also did studies showing long-term follow-up as well. But I want you to notice that with pain, although I don't have those studies mentioned. Oh, yes, I do. Here, the study mentioned talks about how nerve fibers are upregulated in pain. They are often increased in rate more than 2 times. And those of you that are familiar with post-traumatic stress disorder realize it is also associated with an upregulation in the firing rate of nerve fibers. Notice the location in this picture of the vagus nerve, which is indicated by a V here. And notice that it's in the carotid sheath. And notice it's also very close to the sympathetic nervous system, which is just under the deep cervical fascia. And this level is cervical 3. You see the C3 here. And the superior cervical ganglion is also located at this level. What's been found is that if you insert a needle in this space underneath this muscle, that dye penetrates fascia, these layers we talk about, and spreads broadly, found in the brachial plexus and around all types of nerves in the region. A reduction in upregulation of the sympathetic nervous system is proposed. Now, there's also a variation of this treatment that would be treating the vagus directly because, again, the risk with anesthetic is not there. And there are applications here for potentially treating dysautonomia, as we are also seeing the symptoms of dysautonomia change. How could this be important, this injection for PTSD? First of all, it's easily learned for any clinic with ultrasound availability. There is no risk of intravascular injection of anesthetic, so no need for an emergency response team. So this is very important. Stellate ganglion blocks also have therapeutic benefit and perhaps more so, and likely more so than a single injection with the dextrose. However, because there's no anesthetic, you cannot create a seizure and you cannot create trouble with closing the airway. Those are not common, but that's why you need a special emergency response team. This can be done on the field with ultrasound to help soldiers and all kinds of applications for our patients, many of whom have PTSD. Also, it may provide additive benefit to other treatment approaches. You remember we talked about the patient that could now use her PTSD treatment techniques. So we can come alongside other practitioners and afford additional benefit to them to further improve function and limit treatment failures, which by all means we want to do because these patients are often suicidal. What's the status of PTSD data so far? Well, the first box you see here mentions that there is a retrospective quality improvement data that is being gathered retrospectively from consecutive treatment-resistant PTSD patients. These are patients that have failed 2 treatments and 2 medications, and there were 21. That data is being gathered. So far, we've got the data compiled to 9 weeks, and the improvement was twice the minimal clinically important difference on what's called the PTSD Checklist C, or PCLC testing, which was the primary measure they used. There is another study that was approved and was done at 4 sites in the United States. The previous quality improvement data above was done by researchers associated with the University of British Columbia. This randomized trial in the second box is being done by locations in the United States. And this was a weight trial where patients were enrolled and randomized to either wait for 3 months or be treated immediately. This had 38 patients, and now the enrollment has been completed as of the last month. And we'll be following these patients for 1 year. The 3-month blinded data should be available for compilation in the next few weeks. The last study is an ingestion control study. This is the next step in quality, where the D5W will be compared with normal saline. This will likely have 50 patients, and this is being presented to Human Subject Committee in the next several weeks. And again, we anticipate 4 sites in the United States for this. However, if this is of interest to sites such as in India, often the concept we're using now on simple treatments is that if there's multiple sites, each may only need to enroll 10 participants or so and have enough power to be a separate country site for clinical trials. So so that there could be, in a sense, 2 international trials underway at the same time. Now, this is probably, this is to me as a rehab physician, the most exciting new discovery. This is Dr. Myers. He's an internist, and he was using perineural injection treatment. And he found, upon treating a patient with peripheral neuropathy, that this patient said, "Oh, I can move my toes, doc." And indeed, the patient could move the toes better. And this made Dr. Myers think about whether there was some effect on muscle power going on. And so for a number of years, he observed this and refined the technique, realizing that this effect occurred only when he injected under the skin above the insertion of the muscles that were weak, not the origin where the muscle starts, not the belly of the muscle in the mid portion, but over the muscle insertion. Now, you'll see a link here to 5 case studies where this is the introductory publication of the use of this treatment, which we are calling dextrose muscle insertion therapy, or DMIT. I'm going to show you some examples now of DMIT, and for length purposes, I've cut them down to where there's a brief muscle test before and a brief muscle test afterwards. This could be as early as 2 minutes, and you'll see this can even happen sooner. In these cases, it was all within the same session and was minutes to perhaps up to an hour when these patients were tested. So first case, I want to illustrate that this treatment appears to work in subacute situations. Now that means the patient's not done getting better with standard treatments. This patient was 8 weeks post ischemic CVA at the time where she was plateauing in improvement, and the therapists were cutting back their therapy frequency. So notice several muscles that were tested here, and I want you to notice her facial expressions. This is quite surprising to patients. So first is a test of her triceps function.
You keep all blueberries.
Now, sorry, that was, of course, deltoid function, and you could see her power increased, especially in 4 of the 5 muscles, which means you can take resistance. They will show the most obvious change, it appears. Let's go on.
Yeah. Are you trying? I'm gonna push in, and you're not gonna let me bend, but you can see I can overcome that. Push hard. Don't they push in? That's pretty good. What do you think of that?
It's
Go to the
better.
camera.
Wow.
Ready,
Okay.
set, go.
Oh,
You rotate in, and I'm gonna fight you. And you're doing a pretty good job. You go. There you go. Now, ready? Don't let me do it. That's pretty darn strong.
Okay, so you can see supination, pronation tested here, and the surprise of the patient in each particular case that she can now resist the examiner. So let's go on to the next slide. This is an 18-year-old male. So we've now moved to 18 months after stroke. This young man had a small but important dissection or tearing apart within the wall of the internal carotid artery. So this is internal carotid artery, ICA dissection at the cervical 1 level of the neck with resultant right hemiparesis. And this was profound in him, affecting communication and many other aspects. So again, we'll be testing an upper extremity here, both elbow and wrist and the supination and pronation of the forearm. And the wrist will be tested at the last. So note that.
Stiff and straight, don't let me bend it. I'm gonna go towards your mouth. Do it again, nice and straight. That's a big difference. Okay, 1, 2, 3. Okay, way better. Yeah, he's got resistance now. Before he just
It
flopped.
was just flat, yeah.
It's very weak. 1, 2, 3. That's still weak, but
And so notice here that for many patients, a 4/5 power will allow them to be somewhat functional. But the difference between a 4/5 and a 5/5 is a big difference. Also, if they have 3/5 power and can barely lift their foot up, for example, to get up on a stair, if you convert them to closer to 4/5, that can make a huge difference in their functional abilities. So let's go to the next slide. So now we're moving to 30 years post-stroke. This patient had a basal ganglia CVA at age 36. She's now 67. For all those years, she's been catching her toe. Like many people, she doesn't really like to wear braces. So she'll catch her toe several times a day, and she wears out her left shoes. And the case reports show a picture of her shoes with the shoe wear on the left. Notably, as she gets older, because it's 67 now, if she trips, it's a bigger problem for her in terms of fracture. So we're testing before and after for ankle dorsiflexion, which means to pull up the ankle. So here we go.
1, 2, 3. You pull out. You can see
she also can give me good resistance.
Now, we're going to move here to 5 weeks later. So she was still 5/5, and that's what has been noticed is these results are persistent with one treatment. And so this was after she had taken a vacation to North Carolina. And you'll notice her husband describes that she no longer caught her foot, and they actually walked on uneven surfaces in this time away in the Carolinas.
She hasn't tripped in all of her walks when we were in North Carolina. She didn't trip, not one time. So
Are those like hiking trails?
some are hiking trails and uneven ground.
Okay, so that's 30 years post. Now let me go on to the next. This is a patient I saw a few weeks ago who was 40. It is 40 now. And at age 37, 3 years ago, he had replacement of 2 discs, one at L4-5, one at L5-1. And he developed he immediately had an L4-5 radiculopathy and was weak on the right. Now he gained up ankle pulling up and ankle movement in other directions as well. But his big toe was still weak enough, we would classify it as 4/5. Now I'm going to test it in 2 positions. The first position is flat on the bed, the other is with the leg out straight. And then I'm going to show you approximately the area of injection for the great toe extensor. And remember, it's the insertion we're treating. And then I'm going to test him afterward at precisely 1 minute. His wife kept time for me. She gave me a 50-second indication and a 1 minute indication. So let's go ahead and play this. There will be a delay while we wait in real time for the 1 minute to pass. You see the injection here, just subcutaneous. Now we're going to test him again after a delay. So we'll just wait here for a minute. 10 seconds till 1 minute, and she'll give me the 1 minute warning or mention. Now, what are our empiric observations? Obviously, I'm here to talk about looking for research colleagues, because this must be studied. This is so critical for rehabilitation. But here's the empiric observations that have been made so far that are pertinent to study design. And many of them are so helpful for study design that many different types of studies could be performed. There appear to be gains of 1/2 to 1 full grade in 3 to 4 over 5 grade muscles within 1 minute with one treatment, largely permanent, with no time period limitation since a damaging event. Obviously, there's a bit of a learning curve here that's present, and we have for rehabilitation physicians in particular, and therapists, we know our muscle insertions pretty well, but anatomy texts are still helpful for precision here. Effects do not occur with saline injection in the same area above the insertion. And importantly, if you inject D5W over the muscle belly or muscle origin, it does not have the same effect. For study design purposes, we would probably recommend that you estimate a response in 50% of attempts. But for what is being observed, especially in 4 or 5 grade muscles, gains appear to occur in an estimated 75% or more of attempts. Here is a potential randomized trial design as just one example. You could take patients with stroke or CVA more than a year ago and treat 1 or more 4 or 5 muscles, and perhaps have 40 patients. 20 of them could be treated with saline above the insertions, 20 of them with D5W above the insertions of the key muscles. And again, the nice thing is at 2 minutes or so, you can test them with formal muscle testing, which is not what you saw on the videos. So it would be done formally, but it still would not be precise. You need electromyography for recruitment pattern of the muscle or some other objective tests. And you could test these patients at 3 months. You would want to have a reasonable period of follow-up. And then from an ethical standpoint, for just what's right, you would probably offer D5W or actual treatment at about the 3-month period for those that have been kind enough to participate. But notably, they only underwent 1 injection set. So it wasn't as if they were exposed to a lot of invasive treatment in the control. And we would, the patients, of course, would be followed for a year for a good quality study. So here's an overall summary. Dextrose prolotherapy is performed regionally most effectively, it appears, but we have to research it focally. So the results will be limited, and particularly limited because the nerves around the joint appear to magnify the pain and dysfunction in that joint. So nowadays we're looking at the joint itself for prolotherapy and the ligaments around it. We're also treating the nerves around the joint under the skin if they're painful, and we're also treating nerves that are deep around the joint with ultrasound-guided hydrodissection. And with the combination treatment, our success rate empirically is increasing, but naturally, doing all that would be very hard to research. Now, there are actually 9 areas, this is now updated, of level B evidence for dextrose prolotherapy efficacy. Dextrose prolotherapy does not produce scars or abnormal tissue. It appears to produce only normal soft tissue with minimal to no inflammation and only brief osmolarity increase. So what you're reading in the literature about the method of mechanism is incorrect and based on improper exposure for 24 hours to high dextrose levels. However, dextrose does appear to have powerful non-energetic effects, which need to be further explored. Dextrose prolotherapy is important for multiple joint laxity treatment and in part for any situation where multiple joints or areas need to be treated because of its low cost. Perineural injection treatment does eliminate pain from nerves under the skin in 5 seconds, important not only for mapping out the nerves, but also for a diagnosis within the session, because these nerves under the skin have also been found to have profound impact on function. And indeed, Dr. Liftoff in New Zealand treated patients exclusively by using perineural injection treatment and not prolotherapy and not ultrasound guided hydrodissection, and you still got significant benefit. So perineural injection is useful technique for many reasons. For ultrasound guided hydrodissection, D5W is likely the most cost-effective inject aid, likely over saline, over steroid. And empirically, it helps in double crush effects. Research in primary neuropathy has not been done, but it still appears to be a very useful tool pending further research. Next, D5W appears to decrease damaging nerve inflammation. I think we need to stop a second and comment that there's two primary inflammatory systems out there. One is the arachidonic-based system that we've heard of the most, and that the non-steroidal anti-inflammatory drugs like Advil or Aleve, ibuprofen or naproxen sodium work for. And there's nerve inflammation where the nerves themselves produce proteins that cause inflammation. And that's the swelling of the nerves we're talking about. But these special proteins produced by nerves can get into the joints, it appears. There's a law called Hilton that says that nerves that cross a joint also supply that joint. So inflamed nerves around the joint are very important because they can produce things like collagenase that get into the joint. So collagenase is a eating up of collagen, or it can eat up your cartilage. So another reason for importance of nerves. Next, simple D5W may treat PTSD and alter neurologic recovery in ways very critical for rehab. Now, I'm going to take a minute because this is for a seminar for physicians. And I'm going to make a few suggestions for clinical trials, specifically those that may impact patients suffering the most profoundly. Perineural injection treatment. I want to mention period pain in women again. This is extremely common. Women are put on powerful hormone therapies with side effect issues, and indeed, this appears to be very promising and very simple. Ultrasound-guided hydrodissection, specifically the cervical plexus. I've mentioned PTSD as an application, but even within this conference was presented, and we've all seen the dysautonomia, or the dysfunction of the autonomic nervous system, which has several terms now, that is associated with traumatic brain injury. Wouldn't it be nice if we could show that those responses that these patients have can be dampened by a simple treatment such as cervical plexus hydrodissection with guidance? Next, dextrose muscle insertion treatment, subcutaneous now, not into the insertion, but just above it. A study I suggested, for example, was on those more than 1 year post-stroke, but also things like effects on gait. In foot drop could be measured and actually visualized in objective ways. I've also had a very nice physician specialist approach me about, could this help in cerebral palsy? And frankly, we don't know. But I think I would encourage doctors to try this and see how it works for them. And if they begin to develop an interest in research, to please contact us for any assistance. Our desire is just to come alongside for whatever is needed to help the primary authors out. Now that is time for a thank you. It's been a privilege to present. For colleagues interested in research applications, I've already mentioned I'm prepared to assist. My heart is with low-cost approaches. So for potential research-related contacts, please utilize my direct email at deanreevesmd@gmail.com or use WhatsApp with my US phone number 913-963-7750. Kind regards.